All right, let me get started. Um, you know, I kind of, I, I'm kind of glad. The nice thing about Zoom, giving grand rounds on Zoom, is you can sort of pretend, as you sit at your desk or your dining room table, that everyone is just listening to every word that you're saying with like rapt attention. Uh, in person, I gave one grand rounds years ago. I forget like what esoteric thing I was talking about, but I looked out at the front row of faculty colleagues and literally everybody had their eyes closed. And on Zoom, you can pretend that that's not happening. So I wanted to give a grand rounds on something, and I know this is like not starting out well, but uh, something not all that exciting to most people, and that is low-tech, simple interventions for patients who have a grim prognosis. Um, but this is a subject that actually leads to some controversy, and my motivation to put this together came from a very spirited set of discussions with one of our very, very smart trauma surgery attendings about a patient who came in with a very benign looking head CT, a low GCS, and catastrophically increased intracranial pressures, like right after a head trauma, and what to do about that patient. And let's call it the spirited discussions continued into the monthly trauma M&M conference. And we talked about guidelines and what went into the guidelines. And I actually thought I would put together a grand rounds for the trauma surgeons. I don't know if I want to go that far, but that's the reason for this talk. So what do we do in this situation? I want to very briefly just talk about the scope of the clinical question. How common is this? And what do we do in most of these situations? Talk about the medical and surgical management options, of which there's not a whole lot. Review the published guidelines such as they are, and what does the soundbite say? And then kind of do a deep dive. That's going to be most of the talk into the studies used to produce the guidelines, kind of looking under the hood. And then at the very end, what I think will be some very non-controversial suggestions for how to manage this unusual situation. So what is refractory elevated ICP? That's referred to in the guidelines in the papers. To me, and I think in the research setting too, it excludes the lesions that require immediate surgery. If for some reason you have an ICP monitor in and there's a big epidural hematoma, that requires surgery. There's no question about it. The research definition is different among different studies. I say it's 20. I think in rescue ICP it was 25, despite what are described as routine non-surgical interventions. And again, what those are different in different published studies. So for us, our standard medical managements here, as all of you know who take call, sedation, usually with more than one drug, decreasing cerebral oxygen utilization and blood flow through different routes. We use propofol and fentanyl. If possible, ventriculostomy to drain a little bit of CSF, hyperosmolar therapy of different types. I know we've moved more towards hypertonic saline than mannitol. Pharmacologic paralysis, which back when I was a resident was like this crazy thing that we did in desperate cases, and now we do it pretty routinely. And mild hypothermia, that was also very controversial for years and years, and now we do it routinely, very often with a beneficial effect. And this refractory elevated ICP, in my mind, I think of three clinical settings, and two of them I think are pretty non-controversial. And one is, and that controversial setting happens, in my experience, maybe 2 or 3 times a year. One clinical setting is, the patient has a pretty benign looking head CT. We admit them to the ICU. We put in an ICP monitor. The intracranial pressures go up, after 6 hours or 12 hours or a day. And now on the CAT scan, we see blossoming of a big contusion, or we see growth of an epidural or subdural hematoma. I think that's really not controversial. We tend to be very aggressive about doing craniectomies in that setting. The second is, and again, we see this now because of the improvements in trauma critical care, patients who have just terrible, usually pulmonary disease. They've aspirated or they have pulmonary contusions. They're in ARDS. They're badly hypoxemic. They're getting these crazy pulmonary interventions. They're prone and on nitric oxide, or they're on ECMO, in some cases. They're very ill. They're almost always on pressors and CVVH. And usually in parallel with the hypoxic or hypoxemic episodes, their intracranial pressures go up pretty severely. And, we're asked what to do. And I think usually it's fair to say that these patients are not in a clinical condition to undergo craniectomy and other neurosurgical interventions. So I think that's pretty non-controversial. But what about the situation for the patient I'm thinking of, where a little bit of controversy? Diffuse traumatic brain injury, generalized diffuse cerebral edema, and the patient is actually doing okay otherwise. Their patient is not in multiple organ system failure. What do we do? And I think that's where I hope some of these guidelines will become useful. So what are our management options? I know Dr. Gracioli gave a grand rounds a few years ago, describing some interesting research that's going on into what to do about these patients. We really only have two established therapeutic options. One is do a decompressive craniectomy. The other is we used to call it a barbiturate coma, but for reasons that I'll mention later on, it's actually hard to get barbiturates. So now we usually use different drugs like propofol. And the idea is a very, very deep sedation to the point where cerebral blood flow goes down and intracranial pressure may be managed. This is not evidence-based. This is not research-based. This is just kind of our everyday practice. In that situation of refractory high intracranial pressures, despite our usual interventions, what patients are we doing craniectomies on? In general, and I can't speak for all my partners, usually younger patients. I think that's a moving target. It depends on the age of the surgeon. Patients with preserved brainstem function prior to getting pharmacologic paralysis, in other words, patients who come in with fixed dilated pupils, most of us are not operating on. There has to be, we feel, something to save in terms of brain function. This one is a little controversial. I think unilateral cerebral edema or hematomas, if we have patients with both hemispheres trashed with big contusions on both sides, or patients with a relatively benign looking head CT, but terrible raised intracranial pressures, I think we're less likely to operate. That's controversial. And patients who are otherwise medically stable, they don't fit into that category that I mentioned of multiple organ system failure. So is there any evidence to support, kind of what we tend to do in everyday practice? So there are guidelines. I wanted to look through to see, the Brain Trauma Foundation guidelines are kind of the ones that are I think, the best established and the most carefully generated. The docs and researchers who collaborate on them are really internationally recognized experts. These guidelines are regularly updated. And those have focused in recent years on the role of craniectomy. There's actually some updates that were published a couple of years ago. There are other severe TBI guidelines that are out there in the literature, and most of them really do not address this issue. Either they haven't been updated in many years, or they're mainly focused on management of mild to moderate traumatic brain injury. So when I refer to the guidelines, it's the Brain Trauma Foundation guidelines. So I think these are the guidelines that we were arguing about at Trauma QA, and they were updated just a couple of years ago after publication of some good high quality data from randomized controlled trials of craniectomy in refractory high ICP patients. And what I'll do is I'll give you the soundbite that's in like the box of a different color on the website and in the Red Journal. And I think that's what, that may be what we were arguing about. But then the qualifications of the recommendations in the body of those guidelines, which you actually have to open the whole file and read if you want to see them. So here's the guidelines such as they are. And I'll give you my take on early versus late. So primary decompressive craniectomy is the patient rolls into the ER with a big hematoma, and we do a craniectomy. That's primary, even before we put in an ICP monitor. Secondary is patients who are admitted. We don't think they're surgical candidates. They have an intracranial pressure monitor. the ICP is high, and for that reason, we do a decompressive surgery. So that's secondary decompressive craniectomy, or DC. So secondary decompressive craniectomy performed for late refractory ICP elevation. The definition by these guidelines is occurring after 72 hours of the trauma. Occurring after the trauma is recommended to improve mortality and favorable outcomes. Secondary craniectomy performed for early refractory intracranial pressure, that's within 72 hours of the injury, is not recommended to improve mortality and favorable outcomes. And you already see the first little asterisk. The third, I think, is not worth discussing. If you're going to do a unilateral craniectomy, do a big one, not a small one. I think we all know that. And the fourth is secondary craniectomy. This is an interesting one. Performed as a treatment for either early or late refractory intracranial pressure elevation is suggested, but it may not improve clinical outcomes, but it reduces the intracranial pressure. This shouldn't be controversial. And duration of intensive care. And we'll dig a little bit into the literature about what that means. I think there should be asterisks on all of these. And this is what we were arguing about. But if you go a couple paragraphs down, actually, in the published guidelines, you come across these sentences. Unfortunately, neither DECRA, that's one of the two randomized control trials, nor Rescue ICP, together or separately, provides definitive evidence for or against the performance of this procedure. And they are both complex and challenging to interpret. This is the one I would have put as the guideline for non-trauma neurosurgeons, to read. Perhaps the most important conclusion of these studies is that choosing to perform the craniectomy is not a simple decision. The potential benefits should be balanced against the complications and likely outcomes on a case-by-case basis. Okay, so let's look under the hood at the two randomized controlled trials that were used to generate these guidelines. So the DECRA decompressive craniectomy, I think that's what DECRA comes from. This was published years ago. This was 10 years ago. And it was a randomized controlled trial of a bifrontal decompressive craniectomy versus medical management. And the inclusion criteria, and these were actually, when you actually read the study, the actual patients enrolled were a little bit different, were adolescents through older patients, and 59 for a severe TBI patient is old. Severe TBI, Glasgow Coma Score 3 to 8, and no hematoma causing a mass effect. That's an important point. None of this applies if there's a subdural hematoma that we can decompress. They defined early refractory intracranial pressure elevation as greater than 20 for greater than 15 minutes during the first 72 hours after injury, and despite sedation, hypertonics, CSF drainage, and paralysis. They did not use mild hypothermia. These patients were then randomized within that 72-hour after the injury period to what they called second-tier medical management, which included hypothermia or barbiturate coma or a bifrontal craniectomy. And for us as surgeons, it's helpful to look at what they did. So there's a plain X-ray of one of their post-op patients showing they would do a bicoronal incision. They would remove the frontal bone back to the coronal suture or a little bit further, and then use rongeurs to remove the squamous temporal bone that they could see down to the floor of the middle fossa. And this is maybe important if you look at the bottom picture. That's an intraoperative picture. We're looking from behind down at the frontal region. So the bone has been removed. The dura is opened stellate, and you can see the frontal lobes kind of pooching out. They did not divide the sagittal sinus or divide the falx. And, I think people that believe in and do these bifrontal craniectomies often say that doing what was done in this study actually may not be ideal if you're doing a bifrontal craniectomy, because the corpus callosum is going to be, and anterior cerebral artery vessels are going to be strangulating themselves against the falx. So that's been one criticism of the study. So this study, and I'll show you the results, led to the conclusion in that first line of the soundbite that decompressive craniectomy is not indicated for early refractory intracranial pressure increases. There are a few interesting things about the study enrollment and about the outcomes that I think are worth looking at. And they relate to those sound bites. The first is, if you look at this graph of intracranial pressures, they actually decrease to normal in both the medical treatment group and the decompressive craniectomy group. This is the 20 line, if you can't see it from the back row. So if you took these patients and gave them mild hypothermia, high dose sedation, you actually could get the intracranial pressures down, from above 20 to below 20. However, there's a more pronounced effect with craniectomy. So if we go back to the sound bites, in decompressive craniectomy is suggested to reduce ICP. Yes, it reduces intracranial pressure more than medical treatment, but usually medical treatment will lower the ICP to the normal range. The second thing was, it was true if we look at duration of hospital intervention in the outcomes, that the ICU stay was significantly shorter in the surgical patients versus the medical patients, an average of 13 versus 18 days. And there was a shorter duration of mechanical ventilation. But if you look at hospital stay, there was no significant difference. And in addition, there were a lot more, well, I don't have the table here, but there was a lot more surgical interventions in the surgical rather than medical group. The decompressive craniectomy patients, almost all of them who survived eventually got cranioplasties. And a number of the cranioplasties, as we know, were complicated by infections or other problems and required even more surgery. And these patients with craniectomies were actually more likely than the medically treated patients to need shunts. And then some of the shunts, as we are well aware, were complicated by problems and required revision surgery. So yes, the duration of intensive care is lower, but if the argument is being made that that has a clinically meaningful significance in terms of decreasing resource utilization, I think resource utilization, and again, this wasn't addressed directly in the paper, it was certainly, almost certainly, no better with decompressive craniectomy than with medical management because of all the downstream surgeries and interventions that these patients underwent. One thing that I think was noticed very early on about this paper, and this might suggest that maybe there could have been a subset of patients who might have benefited from surgery, is that a significant minority of patients, do I have this here? I do not, actually had fixed pupils in the decompressive craniectomy group, whereas the number of patients with fixed pupils was significantly lower in the medically treated group. So maybe one of the reasons for the absence of beneficial effect of craniectomy was the inclusion of more patients with fixed non-reactive pupils in the surgical group. That might also explain withdrawal of care. So if you look at causes of death, withdrawal of treatment was actually significantly more common. They didn't give us p-values, but it's 50% more likely in the craniectomy group. And that might have explained why patients had a shorter intensive care stay. And again, we're even researchers or even patients in research studies get, what providers think is the best care. And if after all these measures, including craniectomy, the patients remained in a very poor neurologic state with their fixed pupils, that might have been why there was more withdrawal of treatment in the craniectomy group. And that might explain the shorter length of stay. What if we were in a setting, and again, I say it with respect, kind of like our ICUs, where withdrawal of care is very uncommon? Would we have seen a decreased length of stay? Maybe not. One thing we do have to address, especially in the trauma patient population, which tends to skew towards younger adults, is, all these grim outcomes were at 6 months. And people who were in this field, the people who write the guidelines and think about these things a lot, were actually waiting for 12-month data, because a significant minority of young people, even with very bad head trauma, will improve if you wait long enough. 6 months, some people say even 12 to 24 months. And the guidelines people were actually waiting for the publication of more long-term data. And the upshot is that for some reason, the craniectomy group actually had worse outcomes, even at 12 months. If you look at the color coding, this is the original published data. You can actually see there's a little trend towards patients maybe starting to improve in both groups, medical and surgical. Orange is low severe disability, which is patients with a trach and a peg in a nursing home, but who may have some preserved responsiveness. They're not in a vegetative state. That's the reds, and black is obviously dead. Upper severe disability are patients who, in the extended Glasgow outcome score setting, if they live at home, they can actually be left at home without someone watching them for several hours at a time. But they still need help with activities of daily living. With low moderate disability, which is green, patients actually can do some tasks of daily living on their own. They can feed themselves, they can wash themselves. And you can see that there is the green bars and the yellow bars together kind of improved a little bit over the course from 6 months to 12 months, but there was still no benefit from craniectomy, even looking out at 12 months. And the main reason for the worse outcomes was more patients in vegetative states in the craniectomized group. So generalizing these DECRA study results to our clinical practice and to the blanket statements made in the guidelines, just realize all of this applies to young adults. In the actual study, the median age was 23 or 24. Again, no difference between the surgical and medical groups. And the range was 18 to 29, 18 to 34. There were no middle-aged or older adults included, and there were no kids. There were no teenagers, despite the inclusion criteria. So we're talking about young adults, mostly male, as is common in trauma studies. Generalizing to kids or teenagers, I don't think we can do. I think kids and teenagers, we widely recognize that they probably do benefit from very aggressive treatment that we might not offer to adults. And older people who were actually, if you go back to the historic literature, were generally excluded from previous studies of decompressive craniectomy for trauma. One of the inclusion criteria for enrollment in this study was what they called bilateral or diffuse traumatic brain injury on CT. So patients with unilateral injuries were not included. So you have to remember patients with unilateral injuries, a subdural hematoma, what do they call it? A burst temporal or frontal lobe, do not fall into the category of patients covered in this study. And they are more likely, in my opinion, to benefit from craniectomy. I want to focus on this. The median time to randomization, this was said to be the early study, right? Median time to randomization from injury to randomization was 35 hours, no difference between the groups, with a relatively narrow range, 25 to 52 hours for the surgical group, 25 to 45 hours for the medical group. So none of them went out to 72 hours. And none of them went to immediate surgery. In every case, I mean, these patients spent at least a day, with medical management of high ICP before they were randomized to surgery or medical treatment. And I'll come back to that point when we talk about the data for what's described as late decompressive craniectomy. One more important thing that may limit the generalizability to our current practice is that no patients had mild or moderate hypothermia before randomization. And there's no data on the use of how many patients in the medical management group had mild to moderate hypothermia, which we see every week, does decrease intracranial pressures in a significant number of patients. And then the issue of the differences between the groups in terms of non-reactive pupils, which were more common, 27% of the craniectomy group versus 12% of the medically managed group. So going back to those soundbite guidelines, do they support the recommendations? With caveats and with rewordings that I would have done if I was the genius writing the guidelines. You know, I would say yes, secondary decompressive craniectomy performed for some patients with early refractory ICP doesn't improve mortality and favorable outcomes. Even they left a little asterisk. But I would say that the point number 4, that secondary craniectomy is suggested to reduce ICP and duration of intensive care. Even they say, though, the relationship between these effects and favorable outcome is uncertain. I wouldn't have included that because ICP goes down to normal, at least in that study, with medical or surgical treatment. And yes, the duration of intensive care is shorter if a lot of patients undergo withdrawal of care, but resource utilization, hospital stays, downstream surgeries probably goes up. And I think if we're going to discuss resource utilization, that should have been included in the discussion of this guideline. And this is just what I had mentioned before. So if I were writing the guidelines, right, this is like, you know, fantasy world. I would suggest in our minds, even if these are not in the guidelines, that we qualify them in our minds and in our discussions with colleagues based actually on the DECRA data. I would say it's more accurate or precise to say there was no improvement in functional outcomes with bifrontal craniectomy. What it actually showed was worse outcomes, but that makes absolutely no sense. And it can only be, it has to be interpreted with the knowledge that more patients had dilated fixed pupils in the craniectomy group. There was certainly no improvement in functional outcomes for patients who have diffuse traumatic brain injury. Unilateral traumatic brain injury was excluded in the trial, and who have increased ICP, not early versus late, but within the actual study period, 24 to 48 hours after initiation of medical management that does not include hypothermia. If these patients, let's say, mild hypothermia and the intracranial pressures went down, then they might have had improved outcomes. Secondly, I would have said in that point number 4, decompressive craniectomy is associated with decreased intensive care unit length of stay, but the increased need for additional surgical procedures and no change in overall hospital length of stay. So in our minds, that is what I would add to those Brain Trauma Foundation guidelines. So in addition to waiting for longer term outcome data from the DECRA study, the other study that led to the revision of these guidelines was the Rescue ICP study. And this was kind of closer to our everyday practice because we don't do a lot of bifrontal craniectomies for head trauma, for diffuse traumatic brain injury. This was a randomized controlled trial of either unilateral or bilateral decompressive craniectomy versus medical management. Here, the inclusion criteria were a little bit both broader and more restrictive. The study was intended to include children as young as 10, again, a totally different patient population compared with adults, up to age 65, which is very old in everyday practice for performing decompressive craniectomies for trauma, who have an abnormal CT, do have at least one reactive pupil, although as we'll see that wasn't true of the patients actually enrolled. Here, the intracranial pressures were greater than 25 millimeters of mercury, so maybe a little more restrictive than our everyday, or the definition that we use for high ICP in our practice, despite medical measures, in this case, that could include hypothermia. And this is interesting. The decompressive craniectomy type was at the discretion of the surgeon. The sponsors of the study recommended unilateral craniectomy for unilateral hemispheric swelling, bifrontal decompressive craniectomy, similar to the DECRA procedure for diffuse cerebral swelling. This was a study about 4 times bigger in terms of enrollment than the DECRA study. That was something that made it maybe a more powerful study. Unlike the DECRA study, and this is probably due to stratification in the study design, the surgical and medical groups actually were very well matched for all of the variables that were assessed at the time of randomization. Here, interestingly, although fixed pupils were a exclusion criteria, patients were enrolled in the study, but the numbers or the proportions were very similar, statistically identical for the medically and surgically treated groups. One thing to keep in mind is that there was a 37% crossover to the craniectomy in the medical group, which is pretty high, but the analysis was intention to treat. So this is really maybe a trial of trying second-tier measures to decrease ICP like barbiturate coma versus earlier craniectomy in patients with refractory high ICP. This is also important to keep in mind. Only a third of the patients who underwent craniectomy had the procedure that we usually do, which is unilateral. 2/3 of them actually had the bifrontal craniectomy for diffuse traumatic brain injury, the one that was suggested to not be effective in the DECRA trial. And here, the time from injury to randomization has a mean, which is very similar to the DECRA trial. It's 42 hours. For DECRA, it was 34, 35 hours. Here, though, there are longer tails on both ends. Some people were randomized to surgery or medical treatment upfront in 15 hours after the injury, some up to 89 hours. So the means are very close together, but there's more of a spread in the rescue ICP trial. And I'll return to that when I suggest that the distinction between early and late craniectomy is in the guidelines is probably not supported by differences between these two trials. So here, there actually was a beneficial effect of surgery. And this is why I kind of nerded out a little bit on the definitions of these different outcomes in the extended Glasgow outcome score. So overall, with craniectomy, there were fewer deaths and more vegetative states and severe disability. Severe disability is patients who are not vegetative, but are completely dependent for all tasks of daily living in the craniectomy group. There was no increase in moderate disability or good recovery. And those are the green and blue groups. Those are the patients who actually communicate, walk and talk. They may not resume their normal lives, but I think all of us would recognize that those are patients who have regained a meaningful life after treatment of a severe traumatic brain injury. The beneficial effect of craniectomy was that there was some increase in what was called upper severe disability. And the definition is that these patients can attend to at least many of their activities of daily living. They feed themselves or groom themselves or dress themselves. And if they live at home, they can be left at home without supervision for part of the day. And there was no data on how many of these patients were sent to nursing homes versus living at home with their families. I would make the argument that that is a meaningful recovery from what is usually, a non-survivable injury. But we have to bear in mind that, and again, I just have to return to one of our discussions with our trauma team. Our trauma attending said that, these patients, he's seen them walk out of the hospital. That's not supported by the data, but there is a minority of patients who may regain a meaningful existence with decompressive craniectomy. There's data at 6 months and 12 months, as expected. There is a slight increase in what they defined as good outcome, which includes those upper severe disabilities over time. Really no increase in what we would call good recovery. The patients who walk and talk and regain a significant measure of independence in their daily lives. This is really important. When they did subgroup analysis, I don't know why this didn't make it to the guidelines, but the beneficial effect was seen only in patients age 40 and younger. For the relatively modest number of patients age 41 or older that were included in the study, there was no beneficial effect with craniectomy. And this kind of matches our collective observation. It's really young people who benefit from craniectomy and other aggressive interventions. This is also important. When they did subgroup analysis, there was no difference in outcome for diffuse versus non-diffuse brain injury on CT. And the definition was really not given. What I would have been very much interested in is a subgroup analysis of unilateral versus bilateral craniectomies. And the reason is, we have a study of 200 almost patients, the DECRA study, looking specifically at bilateral craniectomy for diffuse traumatic brain injury that showed no beneficial effect, right, across a range of different head trauma patients. Here, the CT definitions of diffuse versus non-diffuse brain injury did not exclude the possibility that there are patients with diffuse injury of both hemispheres, but much worse on one side. And in fact, that would be the reason that the sponsors would recommend unilateral craniectomy, which was done in a third of the patients who were included. Those are patients who I think our experience has been tend to do better, especially if the predominant injury is on the non-dominant right side in terms of functional outcomes. And it would have been nice to have seen a subgroup analysis of unilateral versus bilateral craniectomy. That was not done. There was no data. And again, I understand the study was done the statistically correct way, which is an intention to treat analysis. But remember that a third of the patients in the medical treatment group crossed over to surgery. It would have been interesting to see a post hoc analysis looking at patients who received any craniectomy versus none. And I wonder if there were patients who got 3 or 4 hours of high dose sedation or hypothermia or some other second tier management who continued to have high intracranial pressures and then crossed over to surgery. Would that have shown a more robust positive effect? In this study, unlike DECRA, there were no differences in ICU length of stay and or hospital length of stay. And the authors did not report any data on reoperation or overall hospital length of stay. There was a 24-month outcome study, which was published actually very recently. This is after the guidelines were updated. And again, consistent with what Dr. O'Phelan was discussing a few months ago, there actually were, now looking out at 24 months rather than 12 months, there actually are an increase, small but statistically significant, in patients who have good and moderate recovery. Again, we see here at 6 months, this is the line, the brown line. Here it is at 12 months, and here it is at 24 months. Slowly, there is an increase in patients with, I think, what most of us would consider to be acceptable functional outcomes. And craniectomy, the benefit actually was sustained even at 24 months. Unfortunately, this paper had no subgroup analyses. It just looked at the whole patient population and didn't do subgroup analysis for age or type of injury or type of surgery. So does the RESCUE ICP study support these recommendations? With an asterisk, it does suggest that secondary craniectomy performed for late refractory ICP elevation improved mortality and favorable outcomes. I think that it does not support that conclusion number 4, that even if we think it doesn't improve outcomes, what does it say? It's suggested to reduce ICP and duration of intensive care. RESCUE ICP study actually showed no difference in intensive care unit stays. So if I were writing the guidelines in my fantasy world, or if I was going to suggest what, in my opinion, the guidelines do show, how could they have been expressed or written differently? I would say that there are modest benefits of craniectomy in patients with refractory increased ICP after 15 to 48 hours of maximal medical management. And that benefit is that going out 6 months, a year, 2 years, there is an increased, slightly increased proportion of patients with what's called upper severe disability who can, in theory, live at home and be left unattended for some period of time. Very importantly, these benefits accrue to patients age 40 or younger. This does not apply to older patients. And there's no difference in ICU stay. And just to go into a little bit more detail, I would have suggested that number 1 and number 2 be pooled together because of the significant overlap in the time between injury and randomization in both the DECRA and Rescue ICP studies, the very similar mean times, and just the very broad range of time scale from 15 to 90 or 89 hours, I think in some cases. I would have made the same recommendations. And in my mind, I would make the argument we should consider early, so-called early versus so-called late refractory ICP elevation in the same heuristic, in the same kind of like mental scheme of how we think about them. And I would say that based on fairly good subgroup and fairly strong subgroup analysis in the Rescue ICP study, these benefits, such as they are likely to accrue only to patients who are younger. And the number, the split in the Rescue ICP study was 40. And that's probably an artifact of the mean age. In other words, they had to pick a point. It's nice to have a nice round number, but where there's a significant number of patients both above and below. And I suspect that patients in their early 20s may benefit even more. Patients who are in their late 30s probably won't benefit as much. And I would have added, or I would think in my mind, in terms of resource utilization and ICP reduction, intracranial pressure is reduced to normal range generally, both with surgical and medical management, although more so if surgery is done. I think that's intuitive, especially because we can give medical management after craniectomy, and that was required in a certain number of patients in these studies. Intensive care unit length of stay may be decreased, but not hospital length of stay. And the need for additional surgeries and resource utilization is actually higher when we do decompressive craniectomies. So what factors that are commonly considered in our practice are not addressed in these guidelines? Age, as I mentioned, the issue of preserved brainstem function prior to the patients being pharmacologically paralyzed. There was no subgroup analysis for patients with signs of brainstem dysfunction, pupillary abnormalities, motor posturing, or the absence of motor function in either the DECRA or the Rescue ICP studies. So this does not address patients who might have been included in the study, but who we normally don't do surgery on. And very importantly, factors that were not addressed in the guidelines are unilateral versus bilateral injury. And I don't think that that issue was adequately addressed in either study. It could have been with maybe post hoc subgroup analysis. The final issue is patients being otherwise medically stable. And again, there were patients who could be excluded from the study because the treating physicians felt it was a non-survivable injury. But what that means, whether it's neurologic or due to systemic, non-neurologic problems, there's no data on that. I'll be very brief here. Is there helpful literature other than randomized control trials? I actually looked back at some of the oldest studies I could find going back to the 1980s. There's several non-randomized prospective or retrospective series in the older literature about craniectomy for head trauma. The problem is most of them included craniectomies done for things like unilateral subdural hematoma and were not restricted to patients undergoing secondary craniectomy for high ICP. Some of them did include data. One study, I forget how big it was, these were not huge studies, noted that when they looked at functional outcomes using very, very crude measures of outcome data. Almost all the deaths were in older patients, older than 50, and they recommended not performing craniectomy for patients older than 50. A larger study, 57 cases, though, over 20 years, covering a very wide range of quality of imaging, neurocritical care, medical interventions, even brain imaging. I mean, think of head CTs back in the 1970s. Reported no statistically significant of age on the outcome after decompressive craniectomy for elevated ICP, and they during the earlier years covered would use clinical definitions or imaging definitions of high ICP rather than use of a monitor. They admitted that there was a very small number of craniectomies for patients over age 40, and there were only 2 patients included who were 50 or older, and both of them died. These non-randomized series generally included both unilateral and bilateral craniectomies, and none of them compared outcomes between the two. What about preserved brainstem function? In most reports before the DECRA and Rescue ICP studies, if patients had absent motor responses, meaning a Glasgow Coma score of 3, or they had fixed pupils, they were not included in the studies. There are a couple of recent small case series of patients who had head trauma, came in with fixed dilated pupils, and underwent craniectomy with acceptable clinical outcomes. Without going into too much detail about these small series, I actually read the papers, and in each case, none of these patients underwent surgery after placement of an ICP monitor and demonstration of high ICP. These were patients who within usually minutes of rolling into the ER went immediately to surgery. You know, I think all of us in practice, there are a small number of patients. They come in with GCS of 3. We're not sure if they got paralytics. The patient is clearly in his or her early 20s and has a unilateral injury. And yeah, we operate on those patients. So I think this doesn't change our everyday practice. I have a few minutes left, just to very briefly, because I thought this was kind of some interest. We talk about we don't talk about it very much, but the barb coma. This was a big thing when I was a resident, and it was really, really painful. We see it much less commonly now. And the rationale is if you have raised ICP, despite these usual interventions, if you do very, very deep sedation to the point of what's called burst suppression, where the EEG is flat, except for bursts, those are the bursts, little bursts of activity that occur anywhere from once every minute to once every few minutes, that you can decrease cerebral blood flow and oxygen utilization even further. And this may have protective effects and also decrease ICP. We don't do it commonly because of adverse effects. So, and alternatives, right, in most patients. So at sufficient doses, GABAergic drugs of any type will cause burst suppression. The idea is it can both lower ICP and also decrease glutamate release and secondary brain injury and excitotoxicity. In theory, any drug that works through GABA can work. So pentobarbital and other barbiturates are the kind of historically important ones. Benzodiazepines can be used, and so can propofol. The main adverse effect is hypotension, which was the limiting factor in a lot of the studies that were done of this intervention. How effective is it? There was one very small randomized controlled trial published 25 years ago. It only included 3 patients with pentobarbital. Thiopental was used in the other patients, and that was stopped very rapidly because the propylene glycol that's used as the carrier for thiopental was causing renal failure in patients. That's why we didn't use it anymore. There was a modest decrease of intracranial pressure in those 3 patients. Very large retrospective study, 55 patients, which is pretty big when you think about it. A significant minority of patients, 25%, were able to achieve decreased ICP to the normal range within 24 hours of starting the pentobarbital coma. A significant minority actually had good functional outcomes, surprisingly. And there's one retrospective study showing similar proportions of control of intracranial pressures with pentobarbital in children. Pentobarbital, why don't we see it so much? One reason is that it has a very long half-life. So we have to wait for blood work to come back, which is a send-out lab, before being able to do brain death studies. So that's one practical reason for not using it. Interestingly, I found out just reading about this that pentobarb is used as a euthanasia agent by veterinarians, but it turns out that I think 11 states have now included it in their execution protocols, for convicted murderers. And there was a lot of controversy. There was public pressure put on the companies that produce and distribute pentobarbital to stop shipping it for non-veterinary use. So those companies responded by actually making it very hard to get medical pentobarbital. So it's hard to find. I think there was 2 factories that were still producing it for medical use. One of them had a fire that shut it down. And the other, I think it was a Chinese factory, was shut down during COVID. So it's very, very hard to get pentobarbital. So we now, when we do burst suppression, we're using propofol, which I won't belabor the studies, but there's very little in the peer-reviewed literature. But in what literature there is, it does show decrease in intracranial pressures in not most patients, but a significant minority of patients. So some very non-controversial conclusions after all that. Refractory elevated ICP after the types of routine interventions that we do has a very poor prognosis. Even with aggressive treatment like surgery, the benefits demonstrated in the literature are modest. I think that the guidelines, especially the sound bites, rather than reading the actual long description of the guidelines, are flawed by oversimplification. Reading the guidelines and yelling at us, right, is not, I think a good way of, of addressing these controversies. I would say, and I put an underline here because I don't want to sound nihilistic. I think that younger patients, especially patients in their early 20s, as we've seen, and patients with unilateral injury who have refractory high ICP may benefit from secondary craniectomy. And I think we should continue to do them, whether it's early or late. And in cases where we can't, burst suppression does technically decrease ICP, but it's unclear if it improves outcomes. It's still a tool in our toolbox that we can use, just like craniectomy, in selected patients. All right, thanks very much for maintaining the open eyes. I very much appreciate it.
All right, well, again, good morning. The title is not really self-explanatory. I'm sure you guys are thinking we're going to be talking about robotics, heavy-duty constructs, T10 to pelvises, complex revisions, none of that. And my fault for not having a more straightforward title, but I wanted to get you all intrigued, right? What is heavy-duty spine surgery? It's a concept, maybe even a philosophy. Right now, I've been, 3 years out, seeing patients on my own, trying to figure out how to help them best, and trying to come up with the best way of having good, positive outcomes, having people come back and say thank you, right? Not write angry emails to you. To start off, right? Sumit, I see you're most awake right now. A very simple picture, right? You see trucks, you see trailers, and you're at the desk. You gotta, you coordinate these transportation and cargo shipments. How would you line them up? So you have a big 53-foot trailer. What truck would you assign to it? Right, the biggest truck, right? Then you have a 50-foot boat on the triple axis. Right, exactly. You get the idea, and then you have some Bobcat on the double axis trailer. Exactly. So you have these 4 trucks in your garage, and you can really dispatch any of them at any time. Why not just throw D at every one of them? Hey, it's going to be the safest here. Just take D. You'll get it done. Right, it feels weird, right? It feels like it's an overkill, right? It feels like it's too much resources being wasted on something that does not need to have that, right? So you want to match the torque capacity of each truck to whatever weight and what they need to do. Same thing in the opposite, right? Yeah, when you have a bigger trailer, you're not going to assign a Toyota Tacoma to it because, you know, it's not going to be able to pull. It's going to break down, right? So here we go. Just like that, you've acquired the art of cargo, shipment, transportation, logistics, right? Easy. Take that, make it parallel to spine surgery, and you've understood the art of spine surgery. But before we get to the art, let's talk about basics, right? I think this chart was missed last time when I was doing it on Zoom. So here, I brought it back. You know, I made it, so I'm proud of it. Soak it in, right? Really, spine surgery comes down to two actions that we can do to patients: decompress or stabilize, right? And that's why if it moves, should it not, right? And that's how you think about it. And we talked about decompression before, different forms of it. And that's probably the most helpful surgeries that we can do on patients. But sometimes you have to fuse, right? Fusion is when you think, okay, we have to stabilize this patient, we have to fuse them. But I think maybe there's still a misconception. What exactly is fusion? Matt, wake up. So when you hear, you know, a patient's being booked for a spinal fusion, what do you think of? What comes to your mind? Just don't try to think of a right answer. Just what's in your mind right now? Second eye opens. So, okay, and what entails fusion? And how do you do that? So once you complete your decompression, you put the screws in, rods, you final tighten everything. Now it's super strong. You have fused the spine. Have you? So what is fusion then? What is the fusion part of spine surgery? Do you actually fuse anything? We're not there, right? Creating nuclear reactions, putting cells together. Fusion is a biologic process. Agree? Calcification, mineralization, bone formation, and that's how the segments are connected and stabilized in the long run. So what you're doing, you're providing a temporary fixation, temporary stabilization with instruments, whichever way you choose to do that, right? And the goal of the surgery becomes then, let's stabilize the spine long enough so it can fuse before the hardware breaks. And in a non-viable environment, no matter how strong the hardware is, it will always break, right? You put any cadaver spine into a stress environment, put as much metal as you want, but repetitive tension and torsion and flexion extension will break that hardware out. You'd agree? It's just a matter of time, right? So when you're planning these surgeries, you think, okay, what's a construct that's going to work for the patient, that's going to be giving enough stability for them to fuse before that fails? And there's an escalating, I guess, steps that you can think of. You know, thinking of inside the fusion, almost like a banded fusion, right? You're not putting any screws in, you're not really doing anything. You're corticating, putting bone in. And I was hoping Dr. Lay would be here to chime in on his experience, because I know he does a lot of these with his follow-up. But it's an interesting concept, right? Every time I do an inside the fusion, I almost feel like I'm doing something illegal. You know, I'm fusing, not fusing. I'm billing for fusion, right? I'm not really doing any extra work. Should I really bill for this? But it's an inside the fusion, and I'm gonna have a slide separate, and now we'll talk. Then you can add some wiring. Oh yeah, so now you can feel, okay, maybe you give a little more stability to somebody. Okay, then you can think, okay, let's put pedicle screws and rods, right? And that's what a lot of people, I think of when they think there's going to be a fusion surgery. They think, oh, we're going to get screws, we're going to get rods, we're going to stabilize the segment, right? Any further way to increase the stability? What do you think would be the next kind of the step up on the rods and screws? Beautiful, exactly, right? You get the idea. You can make the construct as stiff as you want by adding these steps, right? So now you have an inner body and you can choose any approach you want. You know, I put those lateral and PLIF and TLIFs together. Personal bias, I'll put lateral slightly, but right, it creates a little more stiffness in my mind. Oh, and then you can also now play with lateral in the body, screws, rotate the patients, do it single stage, and really get a good 360 construct that would hold the segment together well. If you're worried about something, you can add a plate to that. And then you can even go with adding the biologics, PNP, to really speed up that fusion. You can add cement to the screws if you think you really need to have that strengthened, right? And then add bone growth stimulator after if you're still paranoid about your construct, right? So there's all these escalating steps. So just like that picture with trucks, doesn't make sense to really go to the top choice every time, right? Just throw everything at the patient. Why not? Why not biologically? It doesn't make sense. Straightforward statistics, right? The more you do on the patient, the more chances you'll hurt them. For every 100 screws that you put in, if one goes off, and that's your probability of hurting someone, well, every 20, 30 patients, you'll hurt somebody, right? So if you can reduce that number of involvement of invasiveness, you can improve your outcomes, hopefully, or be more selective, right? So that's how you think about this. Okay, so how do I know which construct will be the best? How do I go just strong enough to get infused, but not too much? So now we're overdoing it, creating added risk for whatever other medical conditions you can have. Pulmonary embolism, deep venous thrombosis, MIs, strokes, all of that's on the list of post-operative recovery complication risks, right? Which goes back to the amount of blood you lost, time of operation, time under anesthesia, amount of tissue dissection. So how do you optimize that? There's no handbook on that. No one can tell you that exactly, right? You're in clinic, you can see exactly 2 images for 2 different patients, get 2 different surgeries. Why is that? Right? How do surgeons know which one to choose or what makes them do one versus the other? I think that comes with experience, which I still don't have, but I'm just starting to realize I need to pay more and more attention to different factors that may affect that fusion. Here's a quick slide on insight to fusion. I'm sure it's been present for way longer than that, but a good paper to note in 1995 by Henry Bowman talking about this and pretty much discussing indications for everyone that's not a really good candidate for placing screws in. Elderly, osteopenic, has other illnesses, and you think, okay, if we just do a lot of work, we know it's going to break apart, the screws are not going to pop out, let's just leave an insight to fusion, right? A quick sample case. We had the 78-year-old gentleman comes in with back pain, leg pain. He's in an assisted living facility, but his family brings him over. He's like, he's not comfortable. He does not have a good quality of life. Has incontinence that's developed, and you can see on the MRI, there's canal stenosis across 3 levels. There is signs of some kind of instability. You can see the slips. You can see the vacuum signs in the disc. And then, okay, we can just decompress only, and I'll probably help him with all the neurological symptoms. The back pain will still be present. Should I put screws in him? And I felt like with overall condition, him being sick, nursing facility, elderly, and low bone density, measuring, probably doesn't come up here, measuring the Hounsfield units, right? The big new thing now, thanks to Dr. Elarjani and his seminal article, we can rely on those numbers to give us a preliminary data on the bone density. So here, the vertebral bodies are measuring 25 Hounsfield units. Is that high or low? Low, right? What's a comfortable number? Sorry, go ahead. I'm coming to that, yeah. So what's a comfortable number that you measure? Above 100, yeah, 150, let's say, plus or minus 40, you're in the comfort zone. Okay. When you start getting into 2 digits, you're like, the bone does not look as bright. There's not enough calcium to light up the CT. That's why we can rely on those Hounsfield units that way. So here, the vertebral bodies on the inside are measuring 25, which is extremely low. There's no bone at all, right? It's an empty box. Meanwhile, the spinous processes are measuring in 200s. So you can see it's the way the sclerosis happened in this particular patient over the lifetime, over many years. He's built up that density on the posterior column and has completely weak anterior column, and same in the pedicle. So there's no way you put any pedicle screws in there that they're gonna stay. They're just gonna come out like out of butter. So for this patient, we put wiring in and just did the insight to fusion, decorticated him, right? And put the bone chips. You can see on the right scan there, the way the wires go, they kind of keep all the spinous process together. I felt comfortable. The spinous process felt very dense, very strong. So they shouldn't have broken, right? As patients do well, I don't torture them with imaging unless we're looking for something. So here's a follow-up note. on the follow-up, his family's there, and they state that he feels much better. He thinks surgery helped him. The back pain is minimal, no leg pain, no incontinence. Incision healed well. Right? What are our benchmark of outcomes that we like to hear? Well, number one, if patient's happy, I think we've done something right. Right? We haven't created a series of complications, haven't delayed his healing, and he's doing well overall. That's good enough for me for now. Right? For a 78-year-old gentleman that lives in the assisted living facility. All right, we decide to put screws in, and we'll put a bunch of hardware in different people, and then we start seeing all kind of different complications related to that. There's just some pictures, right? You can see on the left, broken screws. Second picture, lucency around the screw. Third picture, subsidence, and you can see how the cage is being engulfed. The T-lift cage is being engulfed by the vertebral bodies. And of course, cage migration. Why does that happen? Is that because our construct wasn't heavy duty enough, right? Exactly, right. The mobility remains, that wiggles things out, and any metal will break. You just provide enough repetitive motion on it, it will snap no matter what. So looking at this, and then you study your complication, think, okay, what should I have done differently? Should I have added inner bodies on the bottom, on the left one, so that eliminate flexion, extension, flexibility, right? So they can heal. Same thing. Should we have reinforced the screw with a cement to avoid these lucencies? To have a bigger graft instead of the T-lift, put something larger that would hold the pressure and distribute the cross-sectional area distribution. And of course, with the migrations, a lot of times it's from the preparation steps, removing enough disc, leaving that spongy disc that you insert against, and then it just spits it back out, or continuous motion just wiggles it out too. Overall, the failure is the same. The construct didn't hold long enough for fusion to happen. And then once you hit a certain threshold point, that's it. There will be no more fusion. It becomes a pseudoarthrosis. Your construct wasn't strong enough. Do you blame the patient? Do you blame the surgeon? Should you have done something else? No, because there's no handbook, right? We got to go case by case, try to understand it, try to come up with the best factors that we need to check on to think of what is the highest level that we need to achieve in order to be successful. And it's you know, you're in clinic, you're thinking of all that, it becomes very heavy on your mind. You think, just do T10 to pelvis with screws, cement, and if it's complications, their problem, right? At least I'll fuse. You know, it's very easy to fall into that. You have to kind of cross-check yourself at all times. What are the alternatives? Let's say we talked about screws and rods and inner bodies, and then we see people in our clinic that come from the community, private practice, and we see constructs like that. Damien, you had a nice comment to me. What do you think of when you see these type of instrumentations? Doesn't look strong enough, right? Looks like someone like this did the surgery, right? Abandoning the mask, just eager to get money and get away, right? Yes, no, maybe. We probably see the complications of those practices, but probably, you know, the fact that they exist, they do have a good maybe feedback on what they do, and a lot of those people do fuse, right? So hard to judge. Of course, we have our data, we can look into different studies, and there's plenty of them. But if I showed you this, so now you have a case on the left that has no screws versus a case on the right that has inner body, 4 screws, 2 rods, right? And spoiler alert, both of them fused. None of them broken down. Did I overdo it on the right or underdo it on the left? Well, it seemed like both have healed, right? Let's go over kind of one by one. The first one, it's a younger gentleman with back pain. This discitis looking picture, but no real evidence of any infection in there, and just shows us inflammatory degenerative changes within the core of the disc. The end plates on the circumference look completely intact. Joints looked intact. So this is a guy that went for just a standalone inner body from the lateral position. And this is a 6 month, but now it's already been, I think, 2 years out. That has fused. That has not created a problem. It hasn't wiggled out. It hasn't broken apart. So if I had added screws, no one would know about it, right? It would look normal. It would be like, okay, you did screws. It looks like a normal construct. But here I got away by just putting a standalone cage. Doesn't mean that I'll start doing it on everybody, right? Because obviously I won't get away with every case like that. To compare, this is that second case, 58-year-old gentleman, 4-5 spondylolisthesis, no fracture, but you can see on the middle parasagittal CAT scan, the facet space is quite enlarged. You can see the space in black between the SAP and IAP is pretty prominent, the side of a disc, right? So that would probably create instability in motion. Having placed just a lateral cage, you know, it's not really holding anything, right? There's still pivoting and motion instability. So this is the case that I think I showed you before where Aria did the lateral screws and that patient fused, they did well. So both of those, right? Standalone screws, both did well. So now you can imagine if no screws worked and 4 screws worked, 1 screw would work, 2 screws would work, 3 screws would work, right? For the other patient. So when we see that original picture that we thought doesn't look strong enough, but maybe that's all the patients needed. It's a matter of how do you choose them? How do you do the proper selection so you know who's going to be helped by this or who's going to fail? Probably trial and error in many ways. No way of teaching it. I have no way of telling you guys if A then B, if B then C, and you're going to be right 100%. Probably not, right? Just a quick summary. Reduced operative time, reduced blood loss, tissue dissection, hopefully better recovery, better post-operative kind of mobilization. And probably at 6 months doesn't matter for both of these patients. They'll be at the same level of overall mobility and index. And it's those first couple of weeks. How fast can they go back to work? That's important, right? Nowadays, we live in a fast-paced environment. No one has time to sit around and wait for their fusion to happen. So if we can do something less in surgery and get patients out faster, they'll probably appreciate it in the long run, right? Now, if you thought that was okay, 1 level, you got away with it, easy. Now, let me show you this one. This is a crazy one. A 55-year-old guy, young, athletic, looks fit, comes in, but all bent forward, leaning on the cane. Barely made it to clinic. He's had a previous 5-1 fusion. You look at that MRI and you think, I don't know, no stenosis, no real instability, a little bit of end plate changes. You see some inflammation. Just man up, right? Toughen up. Go and do some physical therapy. And he's like, done it all. You can see he's got the core, you know, of an athlete, 6-pack, but he can't hold himself. I'm in bed all the time, he says. I can't do anything, can't work. So something's obviously going on. Is he crazy? You can kind of, you know, get into that, check on him, see, you know, if there's any pathology there. But as you get to know him, you kind of feel, okay, maybe it's somebody we can help. You know, I can see some inflammatory changes. Let's try it. Then, of course, you have a discussion, or I have a discussion with the patient about my realistic expectations, my understanding, and I would tell him, listen, overall, your spine doesn't look bad. But clinically, obviously, you have gone through a lot, all the conservative treatments, injections, therapy. You really maximize. Okay, maybe we can think of something, right? And of course, the posterior complexes look all strong. There's a top right picture that shows perfect facet joints, completely intact. So this guy, we booked him for an additional 4-level surgery. And it was supposed to be with screws, but something happened. This was a VA case with the usual, you know, reason, either trade income or something. We couldn't put the screws in at the same time. And I'm like, oh, okay. Well, let's put the lateral screws, lateral cages, and then we'll come back and do posterior instrumentation, you know, in the near future. We did that, put the 4 cages in, you know, checking him post-op day 1. He's like, all right, still sore from the surgery, you know, difficult. I talked to him and I'm like, let's put, you know, plan for screws at some point. Like, no problem. And, you know, we'll follow up. I felt like a criminal for sure. I'm like, man, I'm letting this patient go. It was just, you know, 4 levels. I feel like I probably destabilized him, right? I did surgery on the 4 disc spaces. I probably destabilized him. He's going to break apart. He's not, you know, he comes back. He's like, you know what? I'm actually feeling okay. Can we wait on the screws? I'm like, okay, as long as you stay in touch. We stayed in touch, you know, called each other up. He's getting better. Now, this was I didn't update the image. It's been more than a year. He hasn't come back yet. And there's one more scan that was later, maybe at 9 months, that showed already that the bottom 3 levels looking very promising. Hard to tell if the fusion's complete, but you can almost trace that white signal across. And the top level maybe was developing a little bit early of pseudoarthrosis, but clinically he was very good. Walking upright, not using the cane. Dr. Vanny knows him and says that his mom still complains about him not doing much, but that's maybe something else, right? When he walks into the clinic, you can see it was a different person. So now I'm thinking, all right, now I got away with 4-level standalones. Back to those pictures, Damien, right? If I just put 1 extra screw, just laid it inside under the skin, you think, oh, that helped fusion, right? You put 2 screws, you stabilize the unilateral site, you do any other fixation wiring. In this particular case, it would not have failed. And you think, oh, that's what helped. or maybe it wasn't necessary. Very dangerous case, right? Don't recommend it for anyone. Don't do it at home. But educational, right? We got away with 4 level of standalones. How did that happen? Right? The facet complexes was strong. There was no instability. His main issue was really that some form of inflammation at the disc space, right? With degenerative changes. It makes you think, and made me think. I'm like, okay, maybe we're overdoing it all the time. How can we make that selection better? And just another example of I got a little more comfortable after that by just putting standalones at least 1 levels. And here's the 5-1, same thing. 5-1 is a key area, right? A lot of strain goes into it, and you think can diffuse. This gentleman is 1 year out, so far very happy. It was just a standalone inner body. This was done in oblique fashion, and I put that buttress plate. I just was worried that it'll wiggle out or move out, but maybe that was even overkill. So there's a lot of studies out there, you know, for everything that you can think of in terms of construct. There's a biomechanical study already done. You can check on it. And there's everything in the literature, depending what side you want to lean on from the beginning, your bias, you can find supporting literature for that. You know, you're against unilateral screws, you find a paper that says unilateral screws fail. You like unilateral screws, you find a paper that says, you know, there's biomechanical stability there. Here's one of these studies here. This was a meta-analysis of everything that was published. They claim to be one of the bigger meta-analyses for the time of 2018. Afterwards, I haven't found any. And they just concluded that overall, unilateral pedicle screws were comparable in outcomes, reduced blood loss. They noticed some cage migration. So obviously, you know, it's not as strong. And on a larger scale, you'll start seeing a little more of a failure. Versus bilateral, where there's an increased incidence of neurologic complications, you have twice as many chances of hurting something by penetrating with a screw, right? Bilateral versus unilateral. So that's 50%, 100%, 200%, whichever way you want to divide that, right? The costs, which we don't need to worry about, but still, in the in the world, it's a real issue. And of course, biomechanical studies do show that you put screws on everything, it is more stable. You put screws on both sides, rods secure, it is more stable, it is more stiffer. But is that an argument to do it in everybody? Is that what patients need? Is that what we need to fuse, or is it ultimate gold standard? Needs to be questioned. Just a study that shows, and here, this is more I want to show you how these studies are done. I think in our department, we don't really do any biomechanicals evaluation studies, right? We kind of do clinicals, retrospective reviews, prospective analyses, but we're missing this part, and maybe it's something that we can all think about and develop further. So, and the setups are very simple. You know, it's a quick setup, solid work, and then you get a nice publication out of it. Right here, they used, I think, pig models, comparing different constructs with intact, just removing the disc, as you see in the middle, the color is missing, and then using screws on one side and one inner body. I think it's like a pliff style inner body versus 2 inner bodies and unilateral construct, just the screws, no inner body, and then everything together. And you almost don't need to do the study. You know the outcomes. You know the numbers are going to be very relevant. The more stuff you put in, the stiffer things are going to be, right? When you start measuring bending and twisting, and that's what it confirmed. The question is, what do we need? What point of fixation, what strength of fixation do we need to help the patient? Just enough. Not overdo it, not adding any risk of post-operative complications, but also don't underdo it that he needs to come back for revision of pseudoarthrosis. There's a study that came out of, and actually included the centers here. Look at this, Spinal Biomechanics Laboratory at Barrows. I mean, they have a biomechanics laboratory. Why don't we have it at Miami, Dr. Levy? Right, we'll talk about it. But I'm just saying, you read about this, I'm like, why don't we do this? And we tried. I'll show you a little experience that we've had with it. Anyhow, in this particular study, they've investigated placing lateral interbody cage. So now that previous one was a PLIF, TLIF, and a lot of people still do it. The industry says the majority of interbodies are still TLIFs, right? Even though in my mind, I feel like the lateral world is really kind of becoming prominent and is the future in terms of placing a proper interbody. And here's a study of comparing that lateral cage with unilateral screws, bilateral screws, or no screws at all. And don't worry about trying to figure out the graphs if you want to. Again, self-explanatory overall. The more stuff you put in, the harder the construct, right? We almost don't need to have studies to figure that out. We know that. help us understand which of these constructs will last long enough in each particular patient. That would be useful. That would be more of a population type of study, right? That would be really beneficial to know. Who can tell me what these screws are? Exactly, right? You can see the screw shaft traversing and perticulating process across the facet joint into SAP pedicle combination, right? And into the body. So it pins the posterior column together, right? And I guess it's a form of fixation, you know, that once you put in that, like, let's say the third image from the left, the model one, you can see that probably will be more difficult to open up the facet joint, right? It will hold on. At the same time, you almost feel, is it really strong enough, right? That surface, those are the bones that always fracture on us, right? That's a part of the reason why we do these surgeries. You have pars fractures, instabilities, and now we're adding strain on those bones. Will it hold? Will it fuse? Who knows? You know, and again, there are studies that looked at it, and look, this is from 2014. It's not a new concept. By then, they already had 5-year outcome and probably a year to write it up. So they started very early. They had 2 arms, 27, 34 patients using pedicle screws, facet screws, and they would watch patient over 5 years. And overall, it was a favorable outcome for facet screws, saying that the EBO was much less, as you can imagine, you know, not worrying about passing the rod, putting the screws in quickly, not dissecting a lot. You can do it in the least invasive fashion. So understandable that blood loss is much less. OR time was less. As you know, passing those rods in certain environments is difficult, right? It's annoying sometimes. Translated to length of stay, that one you can always question, you know, because you can always think of what was the original problem? Were there any bias in selection? And people that the surgeon thought needed that harder construct would just go back to the original. You know, that one you always take with a grain of salt. Implant costs less, but hospital charges were more. That one I don't understand. But also overall, over 5 years, it's not like they saw, as you can see in terms of repair surgeries, any big difference. If anything, the numbers are slightly against the pedicle screws, but I think it's just a statistical glitch. But at least they didn't show that all of a sudden facet screws were breaking out all the time. They needed revision, needed pedicle screws. They actually didn't have any in their series of 27 over 5 years. All right, so that's a screw that looks flimsy, looks small, you know, kind of looks like another bandit move to make, right? But maybe it has enough strength and should be considered sometimes. Here's a case of example. 82-year-old gentleman had a previous fusion, as you can see, previous vertebroplasty, but comes in with back pain, continuous leg pain, and all related to that L5 nerve root. And you can see on the parasagittal view, the foramen is crushed, right? You can see the pedicle is right next to the S1 end plate, and this the nerve is coming out under duress. So what can be done for that? You know, you have a previous screws. It seems like those are PEEK rods. You see they're transparent PEEK rods or carbon fiber rods. Some fancy surgeries had a long time ago, but continues to have this adjacent level or distal level problem. What would be the options? Turkey, what would you do? So expose everything, identify the area, decompress, put screws, take the rods out, connect it to the previous construct. Then you would include levels above, start doing osteotomies, really try and make him look perfect, right? He's 82, you know, he's 82. How much is it? The way I think about it, especially octogenarians, let's say they have 10 years left to live, right? Just being slightly optimistic. Everybody has 10 years left to live. Any surgery you do, that's a downtime after that's going to take away from their life. So you do a bigger operation and it takes a year or two to recover. Now you've taken 20% of their remaining life away, right? That's how I think about it. Should be, right? How much pain should we let them have for the rest of their life, but to have enough quality of life to enjoy it and, you know, and still function, and hopefully not shorten their lifespan, right? And it's not unreasonable to do what you've mentioned, right? You can talk to the patient and outline those goals, and they may feel in line with them, like, yeah, let's do it. I'm ready. I'm willing to take those 2 years to recover. For this particular guy, and just because we're talking about facet screws, I'm using that as an example. Vignesh and I, we did a single stage and lateral. So placed the inner body through the oblique fashion at 5-1 to give him that height. Remember, between the pedicle and the S1 to decompress the L5 nerve roots. And to give him some added stability. Maybe I didn't have to do it, maybe I could have put a plate through the anterior, but to give him added stability, we place those facet screws. Because that was the only structures that looked available readily. Didn't have to deal with the rods. You can see over here, the rods are ending, the tips are right here. The incision is midline. You can put both of those screws through midline incision, just in different directions. We're using navigation. Hey, good morning, Dr. Levy. So we did that, right? Again, was it the right thing, the wrong thing? You don't know until you start following. As Dr. Wang says, nothing ruins your outcomes as follow-up, right? Right now, he's 3 months out. He walks in the clinic, he's happy, right? He's 82, he's happy. He says his back pain is at 3 out of 10. Okay, the goal was never a 0. His feet working, he doesn't have any leg pain. He's grateful, he's thanking me. His downtime was minimal. Now post-operative, 1 or 2 days. I think he did some rehab time as well, but he's back to doing his normal activity that he enjoys to do, right? So I feel like I didn't steal any time away from his remaining life. I didn't fix all of his problems, but that's not the goal, right? I'm gonna take you through that, right? This was a facet screw. No, but this exactly, right? So now I'm looking at this casket and I'm like, look at that left, right? The inner body starts to indent a little into S1. And one of the screws, yeah, exactly. On the left in particular, on the sagittal, it shows even better. You think, okay, I think that's getting looser as well. So I feel like, okay, 3 months, he's doing well. How is he going to do it longer term? I mean, I'll tell you later when he follows up. But of course, it's in the back of my mind. Did I do the right thing? Is that me right now? Right? So far, so good. But long term, maybe he'll break down or maybe he'll fuse. It's a race right now between his body and the construct. And thank you. No, and that's exactly right, right? I can't just bolster and say we did everything right. That's exactly what's going on in my mind as I'm listening to him saying that he's doing well, he's happy. I'm looking at the casket and like, uh-oh, maybe it's not strong enough. What about this one? Who recognizes this screw type? Christian, what do you think this is? What are these called? You can call them anything. Official name is cortical screw. Relying that the trajectory of the screw goes along the cortical part of the bone rather than going into the cancellous portion of the vertebral body for the pedicle screws. The concept comes from orthopedics, in the long bone fixations. They feel that a screw that's with its thread is holding onto a higher density cortical portion is stronger. You can see the advantages of putting this particular screw is that they're coming from medial to lateral. So your midline incision does not need to be as wide to expose the lateral compartment of the spine. Biomechanically, they may or may not be stronger. I'll show you there are studies that, like I said, that show both. But it's something to consider. Now we see this and, patients come in your clinic. Do you think it's a bandit move or is it feasible? As long as it fuses in time, right? And if you do enough of it and all of a sudden they don't fuse in time, then you're not selecting your patients right. Okay. Yeah, bandit, right? And then again, I think this was another study from Barrows demonstrating those cortical screws. And I put pictures up again for us to start soaking it in. I know, Matt, we talked about biomechanical studies and we can start thinking about it, right? The setups, taking the spine models, I think they created a burst fracture. You can see missing a T9 vertebral body part to create instability. And then instrumenting it with cortical screws, pedicle screws, and putting strain on it and looking at all the different parameters. And again, don't worry about the bars and the outcomes. Overall interpretation with that, the cortical screws were favorable. They did work. They hold the constructs just as well. All right, so now we've got this down, right? We know we select the patient, do the right thing, choose the right instruments. I think we're gonna do a 360 surgery, proper interbody, proper screws, put it all in the correct orientation, but then they come back with this. What's going on these pictures? What's the mode of failure here? David, what do you see? Cortical breakthrough. You think this is where the screw was originally placed? It was probably in pedicle direction, right? Just like the other ones. So there's a pull up. So now we're like, okay, everything was perfect. Why did my screws come out? What do you think happened here? Why did it come out? Poor bone quality, yeah. Maybe we put too much strain on the construct, right? Those rods were hyperlordotic and we really brought the screws to the rods. So something was miscalculated, right? The construct felt strong, but the patient didn't want to take it. So looking at that case, what could you do differently then? In the lumbar particular case. Perfect. You can do cement. You can compromise on the rod bending, right? But okay, you choose the cement, and that's fine. And I put the cervical on the side more for us to think about it as we see the next study. There hasn't been a study for the cervical screws like this, and maybe we can do a parallel of some sort. Okay. And if anyone's interested in the biomechanical study, we can set it up. I mean, there are ways for us to set it up. I'll show you one way, and then we have resources. We just haven't really tapped into it yet. Like you said, cement, and yeah, we know if you put cement in the screw, you'll probably anchor it better, you'll hold it better. You can see on the graph, blue line of the screws, the pull-out strength on the screws that are just pedicle screws with no augmentation. Green line is the group 3, and red line group 2. Two different ways of putting the cement, and that's just an interesting technical point. In group 3, they injected the cement through the cannulated portion of the screw, allowing those holes on the side kind of expand and fill in the cement. So you can see the balls of cement around the tip of the screw. In group 2, they would place the screw, take it out, and then in the cavity created would inject cement directly into it, just fill up the hole, and then push the screw right through, allowing for the cement to expand. And that's where you get this cylindrical expansion to it's along the whole screw. And that's a group 2 that showed double as much strength on the pullout, which is an interesting note for us, right? Something to consider if we think, oh, we're just going to put cement. And then you think, well, we have 2 different ways of cementing it. One is stronger. Should we go for the stronger one, for the lighter one, right? You can always make things more and more harder. Here's our attempt. Greg and we've reached out to Biderman Lab. They have a lab set up at Mount Sinai Hospital. Pretty ancient, but they're chugging and they're excited to work. Was not an overall good experience so far. We tried to make it work, as you can see that board picture on the top. That was after probably 5 different meetings of Greg and I driving down to Mount Sinai, meeting with the team, speaking for hours, discussing the case, what we're gonna do. A lot of talking, a lot of, I like more of an action. Let's do it, right? Anyways, we were patient. We tried to do it. We did the constructs. Proposed this tricortical screw. The screw goes from one segment to another, penetrates, and then can we test that? We did N of 1 for each standard versus that. Couldn't break either. Let's put it on hold for now. And it was mostly a lab issue with setups, and we believe they would have experience on testing those things because that's what they portrayed. But it seemed like they were figuring out how to put the spine into the construct to secure it well. So that's why it took a lot of time for us to even get it going. So because of the time issues, I was like, I'm sorry, can't do it anymore. Can't come for another hour, talk about this and not get anything done. So we had to put it on hold, but it's there. If anyone wants, it's right here across the pond, available. We can reach out to Mark Biderman anytime. He's very excited about doing those kind of things. And here's the case. So you think, okay, we put the screws in. There's a cage that you may not see, but you see the dots from the Mark P expandable cage. We put the cement, and like, yes, we did the strong construct. It's gonna hold. This was a 63-year-old gentleman with a metastatic disease, needed to have a corpectomy, had a posterior expandable cage placed in place of the corpectomy. But then every couple of months he would come back with broken rods. I had to have rods replaced, right? And then I had inherited them later after already his fourth surgery for rod replacement. The screws never broke. They never pulled out. But what's been happening, the inner body cage was pistoning into the bodies above and below and just slowly settling, and that created instability and never healed. And that's why the rods kept breaking. So Damien came to the rescue as an intern. He walked over and we did this case together, and we just replaced that inner body cage with a broad lateral corpectomy cage that spans a whole left to right segment. And now it's been 2 years out. It's been holding. The rods haven't broken. And yeah, Damien put another parallel rod again in the lateral position. He comes in like, oh, I'm so excited. I've never done an exposure before. I'm like, well, you get to do it in lateral today. So he was sitting there and thinking that was the standard of care for spine surgery. 2 years out, so far it's holding. Interesting side note complication or a development. He gets SPECT studies for his metastatic disease frequently. And we can see that the first SPECT study after the surgery, the kidneys firing up, they look bright, equal. But over the 6 months follow-up, the left kidney, the side of the approach, and this is right over that area where I had to push everything forward, left kidney stops producing metabolic activity. And it just, I have to note, because was it because of the surgery? Did we created some kind of an inflammatory process that was not evident immediately after surgery, but over time has developed that issue? I don't know. I've looked in the literature. There's been some reports, but nothing's definitive. But I'm throwing it out there, keeping in mind on these laterals, right? Nothing is benign. So now, as you see this, I hope you're not seeing this talk about screws. This is not about screws or how to put them or where to put them. This is more to make us think how much to do. What's the optimum amount of work that patient needs in order for the fusion to happen, right? Optimization. And we talked about different ways of doing it and how which the pictures just show you the mismatch, right? You can have an overpowered under someone doesn't need it, or underpowered for where you need a lot of work. How do you optimize that? And I think it all comes down to those patient factors. There is a biomechanical set of factors, such as how much instability present at the beginning, how much crank you want to put on the spine, how much forces you're going to be applying, the area of the spine you're going to be instrumenting, L1 to L4 versus T11 to L1 are two different, even though they're all 3 levels, there are different biomechanical considerations that go into that, right? And then there's a whole lot of factors that you think they're out of control, right? Patient-related factors, their personality, their mental history, their willingness to cooperate, health status, and all the health factors, weight, bone quality, nutrition, smoking, diabetes, medications they're on, as well as time of the year, right? They're about to get more active. They're going on vacation. They want to do more things. And you're like, oh, you're probably going to need a harder brace or something. So all those things probably play a role. I have no certain way of telling you right now exactly to what extent and what to pay attention. But I think as I go more and more in my practice, maybe I'll generate that more solid dogmatic approach to each patient where I'll have a protocol where everyone would fall into, or for now, it's just all case by case basis. Each person gets an individual kind of evaluation, like, okay, I feel, right? It comes from a subjective interpretation of all of those factors. I feel that's what we should do. And then on the follow-up, you get the feedback. Was I right? Was I wrong? Should I have done more? And hopefully with that loop, I'll continue to refine my approaches. And I urge you to as well, okay? And just a caution warning, right? Just because you can fuse something, no matter how strong your construct is, keep in mind that something else, you don't want to overdo some of these constructs, like in this particular PJK case, right? Happy about lower doses, it fused, everything's holding well, the screws never pulled out, the patient broke down. Did we do the right thing? Stay tuned, that'll be in the future lectures, okay? All right, this was it for me, guys. Any thoughts? There's no questions, I'm sure, but thoughts? You guys have any ideas on how to approach these fusions?